criteria, the sepsis bundle, phases of sepsis, and other controversial topics on sepsis. So first question, this is a 28-year-old female with a chief complaint of fever. She has been having 2 days of cough, colds, body aches, and fever. No? She's awake, conversant, with BP 110/70, tachycardic, tachypnic, febrile, and with a white blood cell count of 4,000 with lymphocytic predominance. Is this sepsis? How about this 28-year-old female with the chief complaint of dyspnea, 2 days of cough, pleuritic chest pain, and like we said, dyspnea, awake and conversant again, BP 120/80 with a heart rate that is tachycardic, tachypnic, febrile with crackles, and white blood cell count of 13,000, segmental predominance with an X-ray showing right lower lobe pneumonia. Is this sepsis? So this is a U.S. textbook, Clinical Infectious Diseases, for which I was fortunate to have authored the chapter 2 on sepsis, severe sepsis, and septic shock. That was in 2015. It's now 2018, and it's considered old now. Okay? So we wrote there that the systemic inflammatory response syndrome consists of temperature of 38 and above, 36 or below, heart rate above 90, respiratory rate above 20, white cells of 12,000 and above, or 4,000 and below. And the sepsis definition then was at least 2 SIRS criteria and infection. The old severe sepsis was sepsis that was complicated by organ dysfunction, hypotension, or signs of hypoperfusion. We know all of these very well, no? Including septic shock, which was sepsis with acute circulatory failure that required pressor therapy after adequate fluid resuscitation. But is this really the definition of sepsis now? We know, and we shall see later on the evidence, that it is sensitive, but maybe too sensitive, and not very specific. And the truth is, this definition does not tell us what sepsis really is. The definition of definition is that it describes the essential nature of the condition or the thing that's being defined. So to tell you the truth, does this really define sepsis? When I talk to residents and ID fellows, I always ask them when I speak about this, what is the definition of MI? And some will say, sir, chest pain, hypertroponinemia, and with or without ECG changes. No? And I would tell them, no, that's clinical criteria. This is the definition of MI. It's simple, heart muscle death with coronary, because of a coronary artery occlusion. No? So in that light, no, the previous SIRS criteria with infection was actually just clinical criteria during that time. This is the new definition of sepsis after the Sepsis 3 panel and task force went ahead and convened and made a consensus. So, and I agree with this, no? There are 4 components now. It should be first, life-threatening. Sepsis should be life-threatening. There should be organ dysfunction. And it's usually because of a dysregulated immune response to infection as the main cause. No? So para matandaan nating lahat, no, I made a mnemonic called LODI. No? Okay. So Gordon, that's idol spelled backward. Okay. Napanapanahon nakakapanahon tong si LODI ngayon eh. So the truth is, sepsis now, as defined, is the old severe sepsis. Because really, SIRS plus infection may really just be a normal response to infection. Remember the first case, that was a influenza case that was not septic, but had almost all the SIRS criteria, but it was not septic in a 28-year-old. So how did they come about this new sepsis definition? Okay, so there was a subgroup of that panel, and that was Seymour et al. And this is what they thought of, though. So they came from the sepsis definition, and from the definition, they thought, who are the septic ones, no? Among the infected patients or patients with infection, those who are really sick, those are the ones who are septic. So sepsis, or the really sick population, became the proxy of sepsis, no? Especially since there's no gold standard. No? And how did they define really sick? No? Primarily, if there was high mortality, or if there was a prolonged stay in the hospital or ICU. So they looked at 21 variables from sepsis 2. They focused on timeliness and ease of use of possible variables, and they did multivariable logistic regression for in-hospital mortality. So they came up with the following, no? Respiratory rate of 22 and above, altered mental status, a systolic blood pressure of 100 and below. If someone meets 2 of the criteria, they would say that's positive for the quick SOFA. That means QSOFA is quick SOFA. So that tells us, no, if it's 2 and above, there's an increased risk of poorer outcomes. No? So they tested QSOFA against the more traditional SOFA and LOD score, or sequential organ failure assessment, and the logistic organ dysfunction scoring that's usually used by other centers or ICUs. Compared to when in the ICU, QSOFA is not as good as SOFA and LODs. But if you look at the right graph, no, or chart, no, you see that QSOFA is actually equivalent when it's used outside of the ICU, and that's good for us, no, because we can use it and without necessary labs, no. And this is the SOFA score. It's easy to download, no, we can get it anywhere. But essentially, the SOFA score is what we use in the ICU, looking for organ dysfunction, whether neurologic, respiratory, cardiovascular, renal, hematologic, or liver. So why use SOFA for sepsis clinical criteria? Because it's familiar, it's easy to use, no? But most of all, because SOFA relates to a 10% chance of dying in the hospital if there's 2 or more, no? And usually, that's the mortality rate, the minimum mortality rate of sepsis, 10% to around 25%. And why a change of 2 from baseline SOFA? Because some people, especially those people with chronic illnesses, may have already a number of SOFA scores at baseline. But if we don't know and that patient only presents to us and says that he was previously healthy, then a SOFA score of 0 can be assigned to him or her. So now these are the clinical criteria that we can use, no? Infection plus 2 or more SOFA points above the baseline can be used in the ICU, or QSOFA of 2 or above plus infection may be a prompt outside the ICU to consider sepsis. But again, these are just tools, no? We shouldn't be too rigid, no? We should remember the definition, we should remember that these are tools, but treat the patient first and foremost. So, septic shock also has a new definition. It's a subset of sepsis in which underlying circulatory, cellular, and metabolic abnormalities are associated with a greater risk of mortality than sepsis alone. And based on that definition, no, they modified the clinical criteria. Instead of just a low blood pressure that is unresponsive to fluids, they also added the cellular and metabolic abnormalities part. And that's where lactic acid or lactate comes in. Okay. And here we see that there is indeed high mortality in someone who has low blood pressure and a high lactate, and even goes up to 42.3%. So that is, in general, no, the mortality rate that we usually assign to septic shock. So how is, and this question was answered by one of our ID fellows, no, Dr. Sebar Sala. Among patients seen at the ER with a suspected infection, how accurate is QSOFA compared to SIRS in predicting mortality? No? So he went ahead and said that yes, this article was direct, was valid, was applicable, and let's just go straight to the results. No? If you look at the first red line on top, no, that's the overall sensitivity of QSOFA, no? 60%, no? Not so good, no? But SIRS definitely has very good sensitivity at 88%. But if you look at specificity, QSOFA has 72%, while SIRS has a measly 25%. No? So SIRS is pretty good with sensitivity, but poor in specificity. And if we look at the more useful ratios or tools clinically, that's likelihood ratios. No? Positive likelihood ratio, it's 2 for QSOFA and 1.1 for SIRS. No? So in this in likelihood ratios, when it's positive likelihood ratio, QSOFA is superior to SIRS. While negative likelihood ratio, QSOFA has 0.5, while SIRS has 0.4. So not that much different. No? So if we summarize those slides, no? SIRS is very sensitive, okay, but poorly specific. QSOFA, on the other hand, is superior in terms of specificity for infection-related mortality, which is the sepsis proxy. In terms of positive likelihood ratio, it is QSOFA that is superior, while negative likelihood ratio of both are equivalent. And therefore, clinically, QSOFA may be more useful than SIRS in diagnosing true sepsis. So do we say goodbye to SIRS in this case? No. I agree when people say, if people are unwilling to let go of using the SIRS criteria, when they say, I don't want to miss septic cases. No? I don't want to diagnose them when they're already life-threatening. And yes, if SIRS is pretty good in terms of sensitivity, I think let's go use it. Okay? I think the new role, and this is my proposal, to continue to use SIRS, no, for screening, because that's the strength of SIRS. But it might need confirmation to diagnose true sepsis, such as adding SOFA or QSOFA. Why? Because having a too sensitive test ends up with too many false positives. No? And therefore, if there are a lot of false positives, maybe the term should be potentially septic. For example, a resident calls me and I ask, is the patient septic? Yes, sir. Then I have to ask, is it based on SIRS? If it's yes, no, maybe I should tell, baka hindi pa talaga septic yan. No? So it's possible, but let's watch. No? But it's not like if we label someone potentially septic because of SIRS positive characteristics, we don't do anything. No? If someone is labeled potentially septic, we still work up the patient. We still give the antibiotic based on the infection and monitor for sepsis development. But for those that we can really accurately label as septic or septic shock, then we start the sepsis bundle or whatever is in your institution's pathway. Okay? But at least by using these two terms, we are able to remove false positivity and prevent over-diagnosis and over-resuscitating falsely positive septic patients. No? So, the old sepsis bundles that we mentioned in our chapter was this. No? There used to be a 3-hour and 6-hour bundle, including antibiotics, blood cultures before antibiotics, crystalloids for hypotension or hyperlactatemia, and of course, lactate. But just this year, the Surviving Sepsis campaign changed this and made the 3- and 6-hour bundles just a 1-hour bundle. So it's now simpler, but there is, of course, the guys who made the 1-hour bundle say there is compelling evidence to do this because there is improved survival when you use the bundles. No? And it reflects clinical reality at the bedside, they said. Because it should be, especially if someone has hypotension, let's start the bundles, get it running, no? But there was negative backlash, okay? The guys who said, no, we don't like this 1-hour bundle, said that the quality of evidence for the bundle elements was low to moderate. And there was high quality evidence, according to them, that this increases utilization of resources without actually benefiting most patients. No? Plus, in the Western world, no, like for example in the U.S., there would be penalties, no, if someone is unable to perform the mandated 1-hour bundle, no. Lastly, adherence to the bundle, they thought, would actually might harm some populations like CHF patients, no, or anuric CKD stage 5 patients, no. Especially since the included in the bundle is this recommendation that at least 30 ml per kilo of IV crystalloid fluid should be given within the first 3 hours with reassessment afterwards, no. But if that is the recommendation and it's enforced by government, no, that will be difficult, no. So let's take a look at fluid resuscitation now, no. Now this is a good study showing that fluid resuscitation should actually be done within the first 30 minutes, no. It's common sense, but at least there's data to support the common sense, no. Here we see mortality is improved, length of stay is improved if fluid resuscitation is started within 30 minutes. No. And look at the graph, no. There's a linear line showing that there's an increase in hazard, increase in length of stay, the longer it takes for fluid resuscitation to start. And this meta-analysis concluded that among patients with sepsis, resuscitation with balanced crystalloids or albumin compared with other fluids seemed to be associated with reduced mortality, no. The guidelines for the Surviving Sepsis campaign, no, tell us that crystalloids should be first line, but the type of crystalloid is not actually specified. Although there is increasing evidence that normal saline is associated with increased mortality and kidney injury, and therefore balanced crystalloids may be safer as an alternative, no. And then albumin, same outcomes, but more costly, so it becomes second line. Okay. And this other meta-analysis did not demonstrate any significant advantage as well with albumin, and therefore crystalloids remain as the first choice for fluid resuscitation. Now, what was the one that was specified in the guidelines saying we should not be using this particular fluid, no, for fluid resuscitation in septic patients? That's HES, or hydroxyethyl starch, no, otherwise known as Voluven here in the Philippines, no. If you look at the electrolytes, sodium is 154, chloride is 154, okay? If we look at saline, or normal saline, sodium is 154 and chloride is 154, far and away from the normal, which is 135 to 145 for sodium and around 100 to 110 for chloride. If you look at lactated ringers, or LR, no, sodium is 130, chloride is 109, closer to what's normal. So actually, normal saline might not actually be normal saline, no, because LR is actually closer to normal. Okay, so saline may cause hyperchloremic acidosis, and it's dose dependent. Sepsis, we need to give lots of fluids, so the risk is higher, okay, unlike balanced solutions. So. Also, saline reduces splanchnic bed and renal perfusion, reducing urine excretion and increasing nausea and vomiting. No? So in my practice, no, I actually use more of LR these days. No? Okay. Now let's go to mortality, no, in regard to liberal fluid administration in sepsis. No? These are a couple of studies. I won't go through them one by one. But the only thing that it's trying to say is that a positive balance, no, on day 1 or 12 hours or 72 hours has been associated with increasing mortality, no, which tells us that we should be wary and be careful with regard to total volume of fluids, no, especially in patients with sepsis. No. So we remember rivers, no? And those were the ones on the top are actually the older trials. The newer trials are the PROMISE and the ARISE. No? Rivers studies would be they usually gave fluids of around 4.5 liters to 5,000, while the newer studies give around 2,000 of fluids in the first 6 hours. And you see, of course, CVP will be higher, no, in those who give more fluids, no. But mortality-wise, fluids in the first 72 hours, no, this is mortality, and the number of liters is on the right side. If you look at the Arise and Promise, they have less fluids, they provide less fluids, and they have less mortality compared to the Rivers and Janssen trials. Higher fluids given in 72 hours, but also higher mortality. And this is an easier way to look at it, no? On day 1, you see that there is an increase of mortality, no, hospital mortality, after you reach more than 5 liters of fluid on day 1. So one thing that you usually forget, no, we used to do this as interns, no, but reassessment, no, after giving fluids, it's very important to go back to the basics of reassessment, no. And the guidelines tell us that we should be using dynamic variables over static variables. Okay? And then these are the static variables: CVP, BNP, all the rest. But that's not recommended. What's recommended are the dynamic variables, such as pulse pressure variation, stroke volume variation, and IVC or SVC, diameter change, using echo. No? But that's too much to do. No? That will require a Swan-Ganz, an A-line, no? And an echo. No? The cheaper options would be to give a 500 ml fluid challenge, no? And the passive leg raise. No? This is the example of using a Swan-Ganz, no, to show and calculate cardiac output there, 5, and stroke volume at 53. And here on the lower left side are the normal hemodynamics. A patient, no, will be labeled fluid responsive if there's a 10 to 15 increase in stroke volume or cardiac output. Pero paano tayo? Wala tayong Swan-Ganz usually, no? Ito, when they gave the 1,000 ml of fluid, nag-increase yung cardiac output and stroke volume by 15%. No? So we always forget yung passive leg raise. No? This is a way of testing for fluid responsiveness without infusing anything. Okay, so we should. That's a good way, no? Especially in our CHF patients. Although baka mahirapan sila saglit sa paghinga when we do that. So one thing that I came upon was this Wind-Kessel formula. It's a non-invasive technique. It's cheaper, easier to implement because you just need the pulse pressure, the heart rate, and to multiply it to 0.002. And allegedly there was good agreement with cardiac output. No? So maybe one thing to explore in the future. No? So the 6-hour bundle we said is gone. No? And even the CVP, we don't use CVP for fluid reassessment anymore. No? Now, this concept of conservative fluid management or de-resuscitation is pretty interesting. No? And it's mostly green and yellow, so in general, there's lower risk of bias. No? Okay, but let's look at this outcome. No? When physicians do this type of strategy, there seem to be less ventilator, there are more ventilator-free days, no? And there is also length of stay decrease, okay? So what are they trying to tell us, no? I'll just go straight here. So if we look at this mortality chart again, no, it seems that if there is late liberal strategy of fluid administration, there seems to be higher mortality. No? And then it doesn't matter whether it's early adequate or early conservative, but it looks like the driver for mortality is using a late liberal fluid strategy. So this is just one example of one way to do it would be to give an initial resuscitation of 500 ml bolus of crystalloid up to a maximum of 20 ml, and determine fluid responsiveness with what we've talked about, no? So that is one example. And this is in general the new concept called, in this case, the SOS de-escalation concept, giving empirical bolus of fluid in the first couple of minutes, optimizing and titrating fluids in the next hours, stabilizing and minimizing infusion in the next couple of days, and de-escalation or de-resuscitation, aiming for negative fluid balance in the next days to weeks while the patient is admitted. It's also called the ROSE concept, to avoid fluid overload. So, the multi-phase nature of sepsis, no? In the early phase, we know, and it's also called the ebb phase, there's a relative hypovolemia. And stroke volume and cardiac output are decreased, and therefore fluids help. But in the late phase, wherein the patient is hyperdynamic, stroke volume and cardiac output are normal or increased. Okay? And there is also microcapillary obstruction from clot obstruction and cell debris, and therefore at this stage, fluids are unlikely to help. No? So this shows, this is just an illustration showing that at this stage, fluids are unlikely to help. No? And Dr. Alejandria, Carl, and I, and a couple other ID physicians are involved in this trial called the HALO International Phase 2 RCT, wherein it's trying to see whether IV unfractionated heparin will help, no, in septic shock. No? In general, it's just trying to act on that phase of sepsis wherein there is a lot of coagulation. No? It's scary, but you know, if it's under the trial, it's worth a shot, especially if there are potential benefits. No? How about procalcitonin? No? The guidelines say that procalcitonin can be used to support shortening duration of antibiotic therapy. And if we look at a couple of meta-analyses, such as this one, no, the diagnostic accuracy of procalcitonin for sepsis is around 0.85. That's the area under the receiver operating characteristic or curve. No? And the sensitivity is 0.8, specificity of 0.77, diagnostic odds ratio of 12.5. Of course, it's much better than CRP when we compare the two. No? But there's also evidence of this, such as this meta-analysis, showing that in procalcitonin-guided groups, no, mortality is significantly lower, no, and treatment duration is also less. Therefore, it's considered safer, and it also helps with decreasing antibiotic use. No? So last would be steroids, no? And this meta-analysis included 21 randomized controlled trials. And this was in 2009. No? The effect of steroids on mortality was considered highly variable based on this meta-analysis. But there was a difference. No? Early on, before 1989, the practice was to use high-dose steroids for short periods, no? And that increased mortality. While trials after 1997 used lower doses of steroids and a much longer course. And there's evidence that it consistently improved shock reversal and even heterogeneously benefits on mortality. No? But when they focused on hydrocortisone alone, no, this was a 2014 trial, no, there was no reduction in mortality, but the shock reversal was still there at 7 days and 28 days. Same goes for this 2015 meta-analysis, wherein there was no significant effect on mortality, okay, even when stratifying with regard to dose, whether high dose or low dose. But the good news here in this trial is no significant effects as well on serious adverse events. No? Now this 2015 steroid meta-analysis as well, in contrast to the latter two meta-analyses, showed some reduction of mortality, not the main one, but for in-hospital mortality and for long course and low dose steroids, but moderate quality of evidence. No? But what is always there and what is consistent is the shock reversal. No? Steroids hasten shock reversal in septic shock. No? Steroids also reduced SOFA score significantly, length of stay in the ICU, without increasing GI bleeding, superinfection, and neuromuscular weakness. However, steroids increased hyperglycemia and hypernatremia. And the most recent meta-analysis, again, no, showing inconsistency again, no benefit in mortality, but there's evidence of shock reversal again, no? Which I would want my patient to, I would want to be able to reverse the shock of, in my patients as fast as I could. No? Now, I'm working with one of our fellows, no, Hani Jane Limos, no, and of course Dr. Isa as well. And we are trying to look at the prescribing patterns in the use of steroids in septic shock. No? And it's simple. No? We just want to know what the practice is of clinicians, no? In terms of usage of steroids, type, dose, method, and timing of initiation. No? But my focus, I think, would be timing. I think that's the key. No? Wala pang big trials, or there's some, no, but not as extensively studied as those. But timing may be the key. No? In your practice, no, do you start steroid when the patient is already on 3 pressors? Or do you start them when the patient is already on 2 pressors? Or do you start them when the patient is only on 1 pressor, but maximal doses already? Or do you start it when this patient is already on pressors and the dose is increasing? No? So, ano kayang maganda doon? No? Hindi natin alam. We might see, no? But the concept is like this, no? If a tree, this saying is like septic shock, if it's already falling, no, is it easier to stop the septic shock when it's at this stage, or will it be easier to stop it at this stage, no? So we'll know. We'll update you when the results are out. But in summary, the new definition of sepsis is LODI. The SIRS criteria is highly sensitive, but maybe too sensitive for sepsis alone. Q-SOFA is superior to SIRS in identifying higher risk of mortality. SIRS can still be used, of course, and I think it should be used as a screening tool for potentially septic patients. No? Q-SOFA and SOFA are just tools. No? The 1-hour bundle is very controversial. The crystalloids are the first line for fluid resuscitation, but LR or balanced solutions might be better. No? Excessive fluid administration may lead to worse outcomes, and we discussed the phases of sepsis. Ebb phase, wherein it's likely to be fluid responsive, while the hyperdynamic phase, unlikely to be fluid responsive. Heparin in sepsis is presently being investigated, may be promising. Procalcitonin may aid in shortening antibiotic duration, although, costs may rise. No? And then low-dose steroid hastens shock reversal in septic shock, but mortality evidence was heterogeneous. No? And timing may be the key. We'll update you. So thank you for your attention. Catch tonight's premiere showing of Sepsis is the Beast, a tale as old as time, but with an all-new and better cast, as you can see there. Thank you so much.
Okay, so in-announce Dr. Buensalido, meron siyang special role mamaya doon, kaya abangan. So in behalf of